So I'd like to welcome everybody, all our members, to the next in NENIC's COVID-19 series. I would like to acknowledge that this is a joint program offering from Boston Children's Hospital and NENIC, and I really would like to thank the education department or professional development department at Boston Children's Hospital. They've just been fabulous, really helping us disseminate information out to our membership with these continuing education programs this year. So special shout out and thanks to the team. And I would like to welcome our speakers tonight, Kathy Turner, who's the Associate Vice President of Marketing at Meditech, as well as Janet Desroche, who's the Associate Vice President for Professional Services at Meditech. And with that being said, I would like to get our program started tonight. Kathy, it's all yours.
All right, thank you, Mary. I will warn people that I'm going to be moving this little banner around during the presentation because sometimes it does obscure the view. So I'm sorry, I know that'll be a little bit annoying, but as annoying as not being able to read the screen. So our objectives for the presentation are the ability to describe 2 methods to assist in the transformation of care delivery during COVID-19 and identifying the impact of surveillance tools and virtual visits in monitoring and assessing patients. And some of the things that we're going to, Janet and I are going to talk through are the COVID teams that we put in place in early January, some of the communication mechanisms that we used, what we did at Meditech for our workforce, the documentation efforts by nursing analysts, virtual care, surveillance, analytics, reporting requirements, and customer experiences. So as all of you know, the timeline for COVID, we started hearing reports in early January, and we formalized an internal COVID-19 team across the company on January 27th. So it was a team that had been previously in place for other outbreaks, for instance, Ebola, and we quickly formed that group and continued to meet on a regular basis to really kind of organize the information, manage it, and disseminate accordingly, not only internally, obviously, but externally to our customers. So our internal communication process, we have an internal website where we posted information and kept that updated. And one of the first things not one of the first things, because it was March actually before we sent people to work at home. Now, our service division was always working at home and connecting to our customers remotely. For our implementation staff and our marketing staff, that was new for them because they were out of the customer sites. In the internal meetings, we immediately said video on, just to kind of keep that connection. But we also offered staff the option to join the front line. So we had a number of nurses that did take advantage of that. One of them actually worked at Boston Hope, the facility that they stood up at the convention center and at the seaport. So she actually worked on the front line there, actually joined us, sharing that experience in our nurse forum the other day. And then for customer support, we changed all of our trainings to remote. Now, some of them had been remote previously, but most of them had been done on live, and switched to virtual go lives, which was quite an interesting process. And then for in our marketing division, any prospects that we were doing demos for, we switched to virtual as well. We're just starting to transition back now to in person. We'll start traveling again on a limited basis in July. But it was an interesting process to move to a virtual go live with our customers. Some were reluctant, some were very willing. They needed to get live and did not want to delay any longer. So we just, had an open bridge line throughout their go live with mutual command centers, and that actually worked very well. As we worked to get the word out to our customers, we had a number of mechanisms really for the general audience. So not specific to our customer base, but published on our website. We had information updated on a regular basis with what WHO was saying and what CDC was saying. And then we certainly took advantage of all the social media options. We did blog posts, emails and newsletters, webinars, and media pitches. We shared with our customers what each other were doing, and I'll show you that a little bit on our customer-specific webpage. But we also were very involved with our Muse organization, which is an independent Meditech user group. And they were excellent at sharing information with each other. They were standing up webinars, almost once or twice a day in the beginning to share what every other customer was doing in that process. So in terms of what with the kind of work we did hand in hand with our customers, and obviously the majority of this fell on the nurse analysts, because most of the, obviously the area that they were concerned about was the clinical documentation and clinical alert and notification process. So we worked on some guidance documents, a 120-page workflow and setup guide for our customers, including decision support capabilities. And we did that. We have 3 different platforms. So we set that up 3 different times to best meet those guidance factors for each platform. And then we worked on a variety of software products and features to either get customers to take further advantage of them, or in some cases, customers weren't even using these yet. And I'll talk a little bit about that in a few minutes and show you the surveillance profiles and algorithms that we used. We did set up a customer service portal that I'll show you in a minute. And then also, I talked about the customer collaboration. So I showed you the general website for the general public. Anybody on ehr.meditech.com could see that. But then we also set something very specific to our customers where we were able to post all of that information, again, as that was rapidly changing, and providing that to the customers. But then we shared specifics about what their peers were doing. Meditech's a very collegial community, and our customers are great about sharing information with each other. So as that became available, as either from working hand in hand with them, or as they were sharing that information, with the news media, we were posting that so that others could see what they were up to and how they were managing that process. As I said, the biggest burden certainly came on the nurse analysts. And I always say, we have the easy part. We impart the information, but then the customer has to go through training everybody on the changes. And, our nurse that worked at Boston Hope, she said every day they would come in with new communication as to the changes in either documentation or protocol. So, communication was just very important on a day-to-day basis. So when we started working with customers on documentation, we first looked, very similar to what we did for Ebola, frankly, we looked at location first. That was the first information that was out there to anybody travel from Wuhan. And it quickly changed to, no, it's all about the symptoms and how do we better track the symptoms of patients so that we can track that. Now, many of our customers had already worked on, the patients over paperwork efforts, so they had streamlined the documentation, and part of our implementation process is the standardization of data elements and documentation. So those that kind of kept true to that had an easier, I shouldn't say very easy, but an easier process of transitioning to take advantage of some of the screening assessments and pre-screening questionnaires that we were doing, because it's those data elements that really allows us to then do some of the reporting on their behalf, as well as some of the algorithms. But the other thing that we strongly encouraged, if customers had not had in place, is taking advantage of that electronic data capture. So, the monitors and vents that are capturing that for the clinicians so they don't have to do that themselves, really saved them some time. And, it's that real-time capture of data then allows you to do that kind of those early warning signs. So we spent some time with customers that maybe had the monitors up, but not the vents yet. And as you know, there was such a deployment of vents, in ICUs as well as other locations that they had to stand up as makeshift ICUs. So that became a very important factor. Some of the workflows that we worked with on our customers were the surveillance profiles. And this is really where those standard data elements came into play, because then we could roll out the risk scores and clinical decision support and algorithms that then showed up in the surveillance tools so we could quickly identify when a patient was getting into trouble, put that indicator right on the status board for the clinician who was, at the patient side, as well as those that were monitoring the patients that were on their unit, so they could have a watch list of all the patients. And I'll show you some examples of that, as well as these dashboards. So the dashboards allowed us to monitor patients more globally, both in an acute care setting, so internal to the organization, as well as in the community. So, monitoring the ED and ICU occupancy, as well as the resource tracking, and then out in the community, some of the testing analysis, importing the CDC data, so you could do some of that trending, as well as some of the geographic locations. Some of the other workflows that we were able to provide for our customers was some of those drive-through testing guidelines. And this is, again, is where the modification to some of the screening components came in place, because organizations were cutting back on what would have normally been a screening assessment, and really just identifying those critical elements. And then as a byproduct of all of this, those data elements are feeding not only our data analytics tool, but also the patient registry. So we can keep track of the suspected and confirmed cases, and then use the lists and email notifications and remote monitoring to keep track of those patients. The other areas that certainly came along a little bit later after some of that was in place was the PPE burn down calculator and the rescheduling of elective surgeries. And Janet's going to talk a little bit later about how do we move forward from here, and what are the things that we need to be concerned about. So just to give you some examples, here's an example of our surveillance watch list and notification. So right on here, I can see that the patient's at risk for COVID, and identifying that as a special risk indicator. Those algorithms are calculated real time, so that the clinicians can get those notifications immediately to their screens, or to their messaging if they're using those kinds of tools. And these algorithms also allow inclusion and exclusion criteria, so you're getting very accurate information pushed to the clinicians. Some of our population-based monitoring and management registries, again, being able to consolidate all of that information, identifying those patients at risk, being able to filter based on key indicators, and then this data being actionable, so I can see what the risk is and then take immediate action with those patients. And then again, I talked earlier about the tracking resources. Here's just an example of the ED, where we're taking a look at that real-time tracking, the capacity management of staff, supplies, and beds, the testing status, and then that activity of pre and post COVID. So all those tools that are so dependent on the data elements that allow us to then provide real-time information to the clinicians. And then here's the example of the geographic tracking that I was talking about, with the heat maps of where and when this is occurring. So I'm going to turn this over to Jana, because she was involved with the National Response Portal here.
So thank you, Kathy, the National Response Portal. So as we know, one of the requirements in the pandemic is for daily reporting to the local health authorities, and that information also goes to the CDC. What the National Response Portal allows for is sharing of data across organizations and disparate vendor systems. And it was created by Google along with SATA Systems. HCA Healthcare, who is a Meditech client, was also a sponsor of this effort. And by virtue of participating and sharing data with the National Response Portal, an organization can have access to these dashboards, so that you can do capacity tracking across geographical areas. You can look for hotspots. And one of the other things that this brings to light is that the data sets that are being sent to the local health authorities and sent to the CDC are now harmonized together. So certainly the profile and the importance of public health has been much elevated with this pandemic. And some of what they're driving in terms of data, we can actually use going forward to manage a resurgence of the pandemic or other types of disease outbreaks. So this is more on the external share data across a geographical area using some of that public health reporting that you're doing daily.
All right, thanks, Janet. So I want to talk a little bit about virtual care, and the reason the tractor is here is because this is one of my favorite stories. We had a physician advisory committee meeting kind of in the middle of the pandemic here, if you can say that we had a middle yet. But one of the physicians was stating that he was doing a virtual visit with one of his patients, and he just found that it was very noisy, and he was trying to figure out where the patient was. So the patient said, well, I'm on my tractor, I'm at work, and I'm able to have this visit right with you right now instead of having to take a half a day off of work. So that one just has really stuck with me, and just really shows the flexibility that the virtual visits and virtual care have provided for patients. So part of that, part and parcel with the virtual cares are the patient side, perhaps using their patient portal to initiate that virtual visit with the physician. But if you look historically, really patients just use that to kind of look at their results, maybe some messaging with their physicians, but they really didn't take advantage of the full scope of that. And we saw a big increase in use in terms of the secure messaging, the access to provider notes, appointment scheduling, and online refills, medication refills, all those very convenient, and now taking greater advantage of everything that they had to offer. One of the blogs that I saw last week is one of the physician clinics had gone back to full operation. Now we're seeing all patients in the office, and they had a 50% no-show rate. Yet when they were doing telehealth, they had 100% show rate. So he was anxious to go back to the virtual visits where they could, make sure that the patients who were scheduled to be seen could be seen. So we certainly think that some of that is going to stay in place. It is interesting to hear different reactions across our customer base, where some are saying that, their physician, they don't know that their physicians will continue to do it, certainly not at the rate they have. And others that have said, no, this is part of our makeup now, and we will continue to do that. Certainly has a lot of convenience for the patient. And I think it will be the patients that will demand it, based on that convenience. You don't have to worry about, if you're being seen, what are you going to do with the kids if you have kids at home? And, and just that convenience, as our, bulldoze worker stated, not having to take time off of work. So we certainly know this is there to stay. I know the funding has been a big issue historically, and many of our customers put that in place to avoid, the readmissions, that they were penalized previously. And although they weren't getting paid for it, they still came out ahead because they didn't have, they were saving in that manner. So time will tell on this, but we certainly know that some of this is here to stay. It'll just be interesting to see how much of that stays. We did extend that to all of our customers free of charge for the first 6 months. And you can see the graph, the increase, from the beginning, probably beginning of, I think this was beginning of March. Whoops, if I move that, you can see the bottom a little bit better until now. So we saw that peak in virtual visits, and then starting to come back down a little bit. The other component to that is virtual on-demand care. So, the typical virtual visit or virtual care, the patient was known to the healthcare organization, but certainly, there was a need to be able to see patients in different venues than previously. So the virtual on-demand care allowed that, whether the patient was known to the practice or not, they were still able to book a virtual visit and kind of auto enroll themselves then in the portal in order to take advantage of that. So it'll be interesting to see what components of this stay post-COVID, or I'd like to say in a better than normal state. But we certainly saw all of this functionality being taken advantage of greater than ever before. And one of our physicians said that he was really pushing his organization to take advantage of virtual visits, and he just got a lot of resistance. And you know, he had the big "I told you so" when COVID came about, and it was then widespread use. You know, and we had many customers that you know, had been using it some, but certainly not to the degree that they did once they sped up that process with COVID. But those that were not doing it, you know, some of them just, you know, didn't think they had the resource to do it, but they rolled it out in short order. And you know, I think they surprised themselves with how quickly they rolled it out. You know, some in just 2 days had it up and running out of necessity, and then we're able to expand it, to take advantage of some of the other functionality here. We just thought we'd share some of the customer experiences. I already shared the bulldozer story, which is one of my favorites, as I said. But we certainly had a lot of firsts in our community here. I talked about Boston Hope earlier. Kearney Hospital was the first hospital in the nation to dedicate that facility to coronavirus patients. We had customers certainly across North America quickly rolling out virtual care. And Avera is actually in South Dakota, has about 100 different points of care that quickly expanded the use of virtual visits as well. And I'll turn this over to Janet to talk about Berkshire.
Thanks, Kathy. Berkshire Health System, a local health system in Western Massachusetts that was hit hard by COVID and continues to have new cases and cases in the hospital. On March 8th, the nurses came together and created a call center. And the volumes of calls continued to increase to the point where they had 6 nurses working 7 a.m. to 7 p.m. for most of the 5 days of the work week. A subset of the calls resulted in the telehealth appointments. So Berkshire's done a lot with telehealth, much of what Kathy just described. And then they also came from not only concerned patients, but patients with, family members with patients at home with high levels of anxiety, whether it be COVID related or a patient who was struggling with another condition and was afraid to come into the health system. So the nurses really came to bat and helped out the patients and helped to reduce some of those anxiety levels. Holyoke Medical Center, one of my favorite stories. Many of you who may live in the area are familiar with the Soldiers Home out in the Holyoke area, where they lost over 70 veterans to COVID. And what Holyoke did is they repurposed one of their units, and they brought into that unit, I think, around 40 patients from the Soldiers Home, veterans who were negative for COVID, and they wanted to protect those patients. And they actually repurposed their physical therapy staff to work with those patients to increase their mobility and to work to keep them well. So I think that is really an amazing thing that they did. The other thing that was kind of interesting that they did at Holyoke is not only did they do a lot with telehealth, but they created a drive-through clinic for their anticoagulant patients. So the patients were actually able to get their lab tests and follow up without leaving their car. So that was pretty amazing as well. So I want to move on. Kathy calls it better than normal, and it's all about getting back to business. So resumption of elective procedures and routine care, and what that, what that means to organizations. So as the curve is flattened and the number of new cases, hospitalizations, deaths have steadily declined, we're cautiously getting back to business with a lot of different procedures, updated infection control, keeping the patients safe, but at the same time, trying to figure out how we can be good stewards of our organization so that revenue can start coming back into the organization. So let's see. Kathy, can you, oh, there we go. Okay. So resuming elective procedures and routine care and how the EHR can help. So we're working very collaboratively with healthcare organizations to determine what do we need to focus on from an EHR tools standpoint. So certainly case prioritization and scheduling. Organizations have to figure out how do they go back and look at those health cases, those health surgeries that span the gamut from elective procedures to cancer procedures. Are there algorithms that we can put in place? Is it committee driven? How do we best reschedule and prioritize those cases that now need to be scheduled and come back into the facility. And then hand in hand testing of those surgical patients. So we've got criteria that we need to apply. If the patient's at risk, how do we actually put them on hold again to be rescheduled at a later time? How do we manage those patients through the various phases of surgical care? That is fairly complex, and a lot of our organizations are struggling with that, but there's a lot of ways that the EHR can help, and we're working with folks to put some of those care protocols in place within the EHR. And then we're not out of the woods as far as managing capacity, potential surge capacity, as well as PPE, ventilators, et cetera. So how do we continue to keep track of what we have on hand, what our burn rate is, and what we need to manage going forward. And then over to the right there, optimizing telehealth. Telehealth, all good, is not going away. However, it's going to take some deliberate effort to increase the use of telehealth in a thoughtful way so that it is effective and that you're optimizing the revenue associated with those telehealth activities. Using technology to support social distancing. Kathy talked a little bit about this, so we have to be careful. We have to keep our caregivers and our patients safe. A lot of organizations are having patients wait in their car in clinics, and how do we use technology so that we can communicate with the patient on their phone while they're waiting, and keep track of how are we doing? How long are our wait times? Are we being efficient with these new processes that are not going to go away? Resource planning, I talked about surge capacity, and then continuing to figure out ways that we can identify and support high-risk patients. So the whole world of infection prevention and control is a new one in the next phase of how we do business. So I don't know if any of the folks on the webinar have looked at this survey that was done by the World Health Organization, and it's pretty staggering but not surprising. So essentially, they took a look at the impact of the pandemic on prevention and treatment for patients with non-communicable diseases. So all those chronic diseases and comorbidities, as well as cancer. So what has been the impact of the pandemic? And it was completed by 155 countries, and it was released at the end of May. And as you might guess, there's been severe disruption to both the prevention and treatment of non-communicable diseases. So 53% of the countries surveyed have partially or completely disrupted services for hypertension treatment, which we know can result in other bad outcomes, health outcomes, including stroke and cardiovascular disease. 49% for treatment for diabetes and diabetes-related complications. 42% reported disruption with cancer treatment, and 31% for cardiovascular emergencies. So I don't think anyone is surprised by this, but it's something that we need to be mindful and is part of the new reality going forward. And as we know, these are the patients that are most at risk for bad outcomes associated with COVID. In addition, they cited rehabilitation services that have been disrupted, and pulmonary rehab is going to be an important part of patients' care when they come off those ventilators and are discharged from hospitals. So we have to continue to look at these areas as we move forward. I'll also mention, I don't have a slide for this, but our e-prescribing vendor with whom we work, they did some statistics, and they are a primary e-prescribing vendor across the country, and they saw a significant decline in new prescriptions. So most all providers now do their prescribing electronically, but in March, April, and May, significant, particularly with the smaller and mid-sized facilities. So that means that patients are not getting the prescriptions that they need to treat a lot of these chronic diseases, these non-communicable diseases. So some of the causes, and again, some of these are somewhat obvious, but decrease in inpatient volumes due to cancellations of elective care, closure of population level screening programs. So those population level screening programs where we're taking care of our diabetics and our hypertensives, et cetera, we need to go back to that. And one of the things that we need to look at is what the impact has been of COVID on these programs, and how do we re-implement those in this new world and leveraging virtual care. Government, public transportation lockdowns, people not being able to get to their appointments. Again, the answer may be with virtual care. So you can go down this list, and many of these we're aware of, but as we go forward in this new world of getting back to business, we have to think about some of these things that need to be adjusted, and maybe we don't go back to the way things were before. We leverage some of the new technology in particular and the new way of doing things to become more effective. So I'll end on this slide. We had a recent nurse forum here at Meditech, and one of the polls that we asked, and there were over 300 or 400, I think there were between 300 and 400 people at that virtual nurse conference. We asked what EHR tools will be of the highest importance moving forward. So over to the right, we asked about contact tracing, which we know is important, tools to better manage supplies, support for enhanced surgical procedure workflows, testing of COVID-19 testing, tools to aid in rescheduling surgeries and procedures, surveillance support. Kathy talked about the surveillance tool, advanced care planning and palliative care. And that's an interesting topic. They also touched on that in the WHO study, the importance of palliative care and how its impact on outcomes. Remote patient monitoring. So during these virtual visits, a lot of the physicians mentioned it would have been nice to have a blood pressure cuff at home that the patient could take their blood pressure, or they could do other physiological measures when they're having one of the virtual visits and virtual care. And the answer that came up the most was virtual care, that organizations across the board feel that virtual care is not going away, and we have to think about the new normal in terms of how do we leverage virtual care. But you can see a number of these others in terms of surveillance and COVID testing, et cetera, were high priority. So these are the areas that we will be focusing on with our clients in terms of providing EHR tools to help them be more effective going forward and getting back to business and keeping patients and caregivers safe.